Okay, thank you for joining us today. Today we have Dr. Thilo Hackert joining us from Hamburg in Germany. Dr. Hackert will be talking about conversion surgery for metastatic pancreatic cancer. Thank you, Dr. Hackert, for joining us. Always a pleasure having you here, and the floor is yours.
Yes, good evening, everybody, and thank you again for the invitation. It's always a nice forum, I think. And this time I chose a little controversial topic, conversion surgery for metastatic pancreatic cancer, which is still a debate between the oncologists and the surgeons, I think. When we talk about metastatic pancreatic cancer, we always talk about this so-called oligometastatic cancer, which is not really defined. Some people say 3 metastases, some people say 5 metastases, some say only 1 organ, some say maybe 5 in 2 organs. So it's not really a consensus on that. And then, of course, we talk about the localization, lymph nodes, liver, lung, or even peritoneal metastasis. We don't know exactly about the type of induction therapy that we should use, FOLFIRINOX or something else, and 6 cycles, 8 cycles, 10 cycles. So these are all at the moment unanswered questions. And then, of course, the most or maybe most difficult thing is how to select the right patients to resect them in the end. Do we rely on the CT scan? Do we rely on the CA19-9, on the biology of the tumor? So these are all questions that are, I would say, hot topics at the moment. So I already told you, we talk about lymph nodes that are distant, we talk about the liver, and we maybe even talk about the lung. When you see this FAPI PET here, you see that the lung on the right side has diffuse metastasis from this big pancreatic tumor in the tail of the pancreas, which is also accumulating the tracer very much. Now, how does pancreatic cancer recur or metastasize? We analyzed this some 5 years ago from 89 studies, 17,000 patients. What were the metastases, what was done, and what was the prognosis, and how to predict who to tolerate or who to treat and who not to treat. When you see this, that you see local recurrence and liver metastasis are the most common sites where you have a problem. The lung is a little less, and also the peritoneum is a little less. However, looking at the survival, the lung seems to be favorable, and I will come back to this at the end of my talk. The liver is, as we know it, mostly a poor prognosis. So the overall survival is always poorer in the liver, but the worst, as you see here, is the peritoneal metastasis. This is a diffuse tumor most of the times, and so oncologically a worse situation. Again, the pattern, I think we can skip this. I want to start with the lymph nodes. You all know that between the aorta and the cava, these lymph nodes are sometimes considered to be distant metastases. What happens when you resect these metastases? And these are old studies. This debate has been going on for 20 years. This is an old study from the UK by Professor John Neoptolemus. You all know him from the SPAC studies. And he analyzed the pancreatic cancer with and without these lymph node metastases, which are considered to be M1. What is the value of these interaortocaval metastases, which are the number 16 in the Japanese classification? You all know this classification. Around the head, you have 13, 17, 12 in the ligament. This 8A lymph node is a classical lymph node. And then you have these 16B1, which are the so-called distant metastases. Looking at this, you see when you resect these patients, there is no significant difference in survival from the 16B lymph nodes. The other factors are much more important, the size and the nodal involvement. And what else you see? The lymph nodes in the ligament are highly significant for survival, also in the multivariate analysis. And I think all of you would take out the metastasis in the ligament to the liver without thinking about it. Nobody would say this is distant metastasis, we stop the resection. But some of us would probably stop the resection when you know there is lymph nodes in interaortocaval space. And looking at the further prognosis, you see the hepatoduodenal ligament metastases are a strong prognostic parameter. These are the 8A positive lymph nodes, poor prognosis. The other ones that are negative, of course, much better. But again, looking at the 16B1 lymph nodes, you see that these are not a significant prognostic parameter. So we are not sure if these are really metastases or not. Of course, if we know there are metastases, we should probably choose neoadjuvant treatment first and then decide for a resection. And therefore, also another Japanese study has confirmed some of these things. Lymph node number 16 has again been evaluated here. What you see is the survival in these positive lymph nodes. 16 negative is somewhere here. 16 positive is not so much inferior. And of course, if the lymph nodes all are negative, this is the best prognosis. But again, number 16 is not the decisive factor. The important thing is if you have one positive lymph node here, this is the best prognosis. If you have more than one, this becomes worse. But the location itself doesn't matter. It's only the number of positive lymph nodes. So the ISGPS has dealt with this some 10 years ago, how to treat these lymph node metastases or not treat them. And then you see that the group of all these surgeons around the world was not sure about the lymph nodes number 16. Some members include this lymph node in their lymphadenectomy. Others do not do this and stop the resection when this is positive. And in the conclusion, no consensus is reached on these lymph nodes. So everybody more or less does what he wants. And I think this has not changed in the meantime, except for maybe doing neoadjuvant treatment on these patients, but otherwise operate them afterwards. Now coming to the liver, I just want to show you some of the studies that show you something about the development, the history, and also the selection. This is an old series from my time in Heidelberg. We had 128 patients with these M1 situation in the liver, as well as the lymph nodes, and we resected all of these patients. Most of the liver resections were only small resections, atypical resections. We did very few big liver resections, right hepatectomies, or even extended right hepatectomies. I think this is also something that is not really done very frequently today. And looking at the outcomes, one important thing is you can do this quite safely. Pancreas and liver resection, 1.6% mortality. I think this is very reasonable. This is very low. And looking at the survival, when you see all of the patients, it varies somewhere between 12.3 and 14 months, where you now could, of course, say this is not impressive because with FOLFIRINOX, you can also only chemotherapy achieve 11 months. But I think there is one thing which you should keep in mind. We have long-term survivors after these resections. This is approximately, let's say, 12 to 15%. And in this study, we did not treat these patients neoadjuvant. Most of them were upfront resected, which of course is not the state of the art, which we do today. So the long-term survivors are important, and please treat them before you think of resecting them. By that time, we did some analysis, the Italian groups especially. We analyzed in some meta-analysis what is the outcome when you resect the liver. 4 years ago, we published. And you see when you resect the liver, you can achieve between 23 up to 56 months of survival. And this is for stage 4 pancreatic cancer. I think very impressive because this is certainly not achieved by FOLFIRINOX alone. When you see what metastases have been resected, mostly, again, this is liver. Sometimes it's lung, lymph nodes, and even sometimes it's peritoneum, but very, very few patients where this has been done. But in the end, when you pool all of these data for the liver, surgery is favorable in some of the patients, and so you should at least consider doing this after a good pre-treatment of the patients. How to select the right patients? This is also some debate that is, as I said, not really solved at the moment. And therefore, I like this rather small Italian study. 127 patients with metastatic pancreatic cancer, all of them had primary chemotherapy, and then finally 10% were resected, 11 patients only. You can say, okay, this is not relevant, so why do I show you this study? Looking at this study, some interesting aspects. The first aspect is nobody knows which therapy. Chemotherapy in this study was FOLFIRINOX, sometimes it was gemcitabine and oxaliplatin combined. Then there were some other schemes which are probably not used today anymore, but this just tells you we just give something, see if it's responding, but we don't know which patient needs which chemotherapy. Today, probably most patients get FOLFIRINOX or gemcitabine nab-paclitaxel. This is, I think, the standard at least at the moment. When you look at the resected patients, only 11 patients, as I told you, much better survival, 3-year survival of 57% after this metastasis resection, compared to 5% of the patients that only had palliative treatment. Of course, this strongly supports resection in the correct patients, in the right patients. And now the second interesting aspect of this study is how to select. And the predictors for a good outcome, for a good survival in the analysis of this little study were the number of metastases. Again, I come back to what is oligometastasis. When you have more than 5, you should not consider resection. If you have between 1 and 5, you have a good outcome. The survival is not significantly different. So up to 5 metastases seems to be feasible and reasonable. Then again, what kind of therapy? You need a combination therapy. Only gemcitabine does not help the patients. But when you have a multiple agent chemotherapy, for example, FOLFIRINOX, this is what helps the patient and what leads you to the resection in the end. And then the last thing, and this is again predictive parameters that we use mostly today, is CA19-9. The biology tells you good biology when the CA19-9 decreases under the chemotherapy. If the CA19-9 stays the same or even increases, this is a poor prognostic factor. So you should not go for resection in this, and you should skip these patients from your operating schedule. So these 3 criteria may help you at the moment. They are not perfect, but at least they give you some direction which patients you could potentially consider for a metastasis resection after, as I said again, a good pre-treatment with a multi-agent chemotherapy. Now, of course, by the time before I left Heidelberg, we updated this experience a little bit and looked at what we had at the end of this period. These were finally 173 patients with M1 pancreatic cancer. You see the lesson that we learned was all of them had neoadjuvant chemotherapy, and only afterwards, in a stable situation, we considered a surgical exploration and finally, eventually, a resection of metastasis and primary tumor, or maybe metastasis after primary tumor. We also learned that FOLFIRINOX is the best. 60% of the patients received and tolerated it. Some patients who didn't tolerate this strong and tough regimen had a gemcitabine-based chemotherapy, approximately 32%. And then, of course, some also received other combinations of chemotherapy. We never did radiation in these patients, which everybody can understand. If you have a systemic problem, you need a systemic therapy, not a local radiation. This will not help the liver. This might help the local tumor control, but the local tumor control is not essential. Finally, we could resect 54% of these patients. And I think, interestingly, 48%, 1 out of 2, had a complete pathological response, which means you open the abdomen, you see the liver, you see there has been some metastasis, there has been some white thing, there has been some scar. You excise these metastases, which you, of course, know from the CT scan before the chemotherapy. And when you take out these metastases, half of the patients have no viable tumor anymore. This is only scar tissue. This is only alterations around, like fibrosis. But of course, also 50% still have a viable tumor in there that the pathologist confirms at the end. And looking at the characteristics, at the prognosis, the resected patients had, of course, a better response in terms of biology, which means the CA19-9 has responded and has gone down, mainly into the normal range below 37, but also into a range which is below 400, coming from, I don't know, maybe 1,000 or 2,000, but they have responded. And so these are the ones that will be resected and that will be not only undergo an exploration and then stop because you cannot resect because you find more than you expected. And then again, of course, also these patients often have a negative lymph node stage, which means a pre-treatment N0 stage. These were approximately 60% of the patients who underwent a resection. And the other ones that were not resected finally also had a positive tumor stage, which was confirmed by sampling some lymph nodes around the aorta or some lymph nodes around the pancreas. So these are the things that show you the response to the chemotherapy, drop in CA19-9 finally, and when you resect, negative lymph node stage, although you can imagine probably all of these patients that have metastasis in the liver also had positive lymph nodes by the time of diagnosis and by the start of the chemotherapy of the pre-treatment. And these, of course, again, are the significant differences between the ones you should choose for resection at the end and the ones where you should not go on with the resection, even if you can maybe technically do this. What are the survival prognostic factors? If you can resect the metastasis, this is the strongest survival factor, I think, because then you have taken out everything. If you have a full response, this is the best you can achieve for the patient. CA19-9, 400 as a cutoff might be a reasonable choice. We don't know the correct cutoffs because we will never have any randomized trial on the correct cutoff. Some people say it should be in the normal range. Some people say it should be below 400 or below 500. Some say below 100. And some say it should drop approximately 90%. This 90% rule might also be something you can use. But if you imagine, sometimes you have patients who have a 150,000 CA19-9 and they drop approximately 90%. They still have a 15,000 CA19-9 in the end after induction therapy. And these are the patients that probably do not benefit in the end. So I think a absolute cutoff like 500, 400, or 100 makes more sense than a relative cutoff of 90%, because 15,000 CA19-9, as I told you, still is a poor prognostic factor in my point of view. And then the third factor, which might be important, is the timing of the operation. If you have 9 months of chemotherapy before, which is tough for the patient, of course, 9 months of chemotherapy, you have side effects, you have toxicity, you have the fatigue, you have everything, is tough for the patient. But if the patient makes it for 9 months and then undergoes the resection, this is also a very strong prognostic factor. Of course, this only reflects the selection effect, because these patients are the ones that certainly have a good tumor biology and have a strong condition. So they will make it through the chemotherapy, they will make it through the operation. And this is the reason why 9 months of pretreatment is favorable to maybe 5 months or 6 months. But again, this is some matter of debate that we have not finally clarified, and probably every center does a different regimen. I think most of the centers agree that 6 cycles of chemotherapy should be the standard minimum, but also maybe 8, maybe 9, maybe 10 cycles. This, as I said, is not solved, and you cannot find any reliable data to support one or the other. And now looking at the outcomes, I told you in the first series, it was approximately 12.7 to 14 months. In this series, you had approximately 25 months when you had a full pathological response. So these are the really good responding patients. And this strongly supports doing this kind of surgery. And you have 1 out of 3 surviving for 3 years, which means, look this line here, this is 1 out of 3 surviving 36 months. And when you can add afterwards an adjuvant chemotherapy, this becomes even better. Again, tough for the patient. He might have had 9 months of chemotherapy before, then he has undergone the resection, he has finally recovered, and then you go to him and say, okay, now you need another 4 or 6 courses of adjuvant chemotherapy. A lot of patients might either not tolerate it from their condition, or they might just say, I don't want that anymore because I'm just fed up with the chemotherapy, so leave me alone. But if you can do it, you can achieve 30 months of median survival and 40% of a 3-year survival, shown here in this red line, 3 years, 40%. And again, I want to emphasize this is for stage 4 pancreatic cancer. Otherwise, palliative situation. 10 years ago, I think nobody would have expected this, and everybody would have said you are crazy if you operate these patients and if you expect a 3-year survival of this collective of patients in this situation. Now, one thing that we also investigated was can we rely on the CT scan to predict resectability of the metastasis? This was, again, from more or less part of this collective I already presented to you, resection of 43 patients who all received FOLFIRINOX in an M1 situation. And we had a look at the imaging, of course, at the CA19-9 and other parameters. How can we select the right patients? And of course, some patients react like this, tumor before, tumor afterwards. This is clear. Everybody says, brilliant response, you need to operate this patient. Some patients look like this, and then after FOLFIRINOX, they look like this. Everybody says, I don't know, has this really responded? At least it is stable. It has not gone any further metastasis, maybe, but you could not predict if this is really a good response or if this might be the same as before the therapy. So the CT image does not really show you. It might show you a little shrinkage of the tumor, as you can see here, but it's not really reliable. Now, what did we resect in this collective? Again, 2 to 5 liver metastasis. This is what I showed you before. Don't go for more than 5 resections. We resected 6 metastases in very few patients. This was a little bit out of the border, but we did it from time to time. But mostly it was 2 to 5 and mostly in the liver. And the parameters that finally predicted a resectability and a good outcome was shown here. Primary tumor shrinkage, so the CT scan can give you a little advice, but it is not the utmost thing, as I told you before. And then the CA19-9 after the therapy is the best important factor for the prognosis. If it really decreases, it helps you to select proper patients for proper operations. The delta, the relative drop in CA19-9, was not really predictive. You can see these lines are almost about the same. This is what I told you before with these 90%. This is nice. This might be something you think, okay, very good, but it was not an independent factor of prognosis for resection. This was the absolute value and the response of the primary tumor in the CT imaging. And doing this, finally, we achieved something like approximately a little less than 2 years in median in this collective. But again, we did have some long-term survivors, 36 months, 48 months, which for pancreatic cancer already is kind of a long-term survival. Now coming back to the lung, in the beginning I showed you that the lung metastasis should somehow have a better prognosis than the liver metastasis. And again, this is only small series. I chose this series, which was done in Munich mainly, 2 centers putting together their lung resections of pancreatic cancer, only 11 patients. You see, disease-free survival is not so much impressive. Total survival for metastatic pancreatic cancer is quite okay. This is somewhere around, let's say, 3.5 years. Overall survival after the metastasis diagnosis was again something like 28 months. So yes, it is worthwhile to also resect some pulmonary metastasis if you again choose the right patients. And how to select them. One thing which is kind of an addition to what I told you before is the time between the original operation, resecting the pancreas, and the occurrence of pulmonary metastasis. If this increases up to 32 months, then this is a very good prognosis. And of course, also the time after pulmonary metastasis, you see the difference in low grade and high grade histology. And the low grade, of course, does much better than the high grade, the aggressive tumors. This is not new, but was a little bit of confirmed in this study. In this study, interestingly, the CA19-9 did not really work. So these curves with a low and a high CA19-9 were not significantly different. And also the numbers were not significantly different. One nodule compared to multiple metastasis did not make a difference. So maybe the lung is a little bit different from the liver in terms of CA19-9, as well as maybe in terms of the number of metastases that you might resect. Now, 2 years ago, the Japanese Society put out some consensus paper, some position statement on how to define the correct patients for metastasis resection. Did this based on the literature that was available, 23 studies that were used here. What you see is something that I already told you. You should resect oligometastatic patients, not too much metastasis, no other sites, beside the liver, so only one organ which is affected by the metastasis, you should expect margin negative resection of the metastasis, of course. So this is also something which might be important. If you take out a metastasis from the liver, you just take it out radically or you don't take it out. And then you should do 9 to 12 months of pre-treatment. This is very much in line with the data that I showed you from this series in Heidelberg. 9 months pre-treatment and then consider resection. Do not do this before, not after 4 months, not after 5 months, 9 months, and maybe even better 12 months. When you do this, you can really improve your results. When you do upfront resection, this was the data I showed you in the beginning, 6 to 22 months. With 22 months, you are already lucky if you have these patients. If you have induction therapy, good induction therapy, 34 up to 56 months. And by the time of the second surgery, it's 24 to 46 months, still up to 4 years of survival. But you should really keep to these criteria, to these recommendations, and then only consider doing this. Now, the Japanese colleagues are a little bit more aggressive than we are. We know that from the last 5 to 10 years. And they, at the moment, are addressing peritoneal metastasis. This is an ongoing randomized controlled trial in Japan. 30 institutions are participating. 100 patients are planned. If you have peritoneal metastasis, you can do intraperitoneal chemotherapy with paclitaxel and S1, which of course is not usable in Western countries, neither in Egypt nor in Europe, because the Western people do not respond to this. They cannot metabolize this S1. But of course, the Japanese people can do this. And then they give this as a HIPEC in this study. And one of the outcomes after the intraperitoneal administration by randomization is conversion surgery, which means do you have a benefit from HIPEC in this situation, and then resection if the patient remains stable and can be technically operable after this pre-treatment. So this is, of course, something which is also not really done in many countries, I think. As I said, the Japanese colleagues are a little more aggressive than we are at the moment. We do not do any HIPEC at the moment for peritoneal carcinomatosis from pancreatic cancer. This has been done in, I would say, very anecdotal reports, maybe some 1 to 5 patients in some published series, but certainly not something that is recommendable to do it without generating more data, maybe also from this study. So looking at the current guidelines, this is the guideline in Germany from last year. This is from 2023, and this is in German, but I will show you what is written here. You can resect a primary tumor if you have less than 3 metastases, if you include the patient in the study. This is what you should do best. If you have more than 3 diffuse metastases, you should not resect the patient. But if you have only, again, 3 and they occur after your primary resection, you could include in a study and you could maybe think about resecting these patients again. There are 2 randomized studies going on at the moment in Germany. I just want to show you these 2 studies very briefly. This is the so-called MetaPanc study, which is done in Göttingen in Germany. This has now just been initialized, and this study includes up to 3 metastases if the patient has this less than 3 oligometastases. And at the moment they are recruiting. They have planned 272 patients, and at the moment they have recruited 6 patients. So you see this will take another, let's say, 3 to 4 years at least until we have results from this study. Planned completion of the study is 2027. I don't believe it will be finished in 2027 if you see that at the moment it's only 6 patients included. And this is the current state. I just looked it up before the talk. So this is what is going on from this study. And then you have the so-called PolyPanc study. This is performed from Cologne, also a multicentric study. This is a little bit more liberal. 5 metastases can be included. And you have a little different chemotherapy, not FOLFIRINOX, but you have irinotecan liposomal. So this is a bit different than you have in FOLFIRINOX, but this is the pre-treatment planned in this study. And this study is also recruiting, and the study has been going on for a little longer time now and has recruited 77 patients. So you see, you can do such studies. It's feasible to do this. At least in a multicentric setting, you can do this. Probably not monocentric, then you will never recruit these patients in the numbers that you needed. But also this study will still take some time to be completed. 150 patients are planned in 14 centers that are working at the moment. So it might take maybe, let's say, 2 years until we have the results from this study. Might be a little earlier than the MetaPunk study that I showed you before. Now, putting all of this together, I think metastasis resection in pancreatic cancer is feasible. You can think about this. You can do this either synchronously, or you can also consider it metachronously when you have had a pre-treatment of the patient, what I told you before. You can achieve a long-term survival in liver, in lung, and in lymph nodes. In peritoneum, I have severe doubts that you will achieve a long-term survival. Probably you will not be able to prove this. But most importantly, finally, there are studies ongoing. I showed you 20 years. We did this just, let's say, by occasion. You have some little metastasis, you take it away. But we did not do good studies. And at the moment, there are at least 2 studies in Germany going on, which will deliver some evidence for the future, and especially also deliver some evidence regarding the correct selection, not only the efficacy, but also which patients to select at what point of time to resect primary, plus, minus, liver synchronously, or maybe also metachronously. So I think that was the most things that I wanted to tell you, the most messages. So there is some development in this field. It's not a completely palliative situation anymore, but of course, you have to be careful. You have to select very wisely, and then you can really achieve a benefit for the patients. So thank you very much.
Thank you for your wonderful talk. And let's start by taking some questions from the audience. Please, if you have a question, raise your hand. Any questions from the audience? Please, if you have a question, raise your hand. Any questions? I'm looking for Dr. Medhat Kapagi. He always starts by questions, but
He always has the questions.
yeah, but he got disconnected. Okay, any questions from the audience? I have a quick question. You mentioned briefly something about S1 being utilized in Asians and not in Egyptians. What is that?
S1 is a kind of an oral modification of 5FU, which is metabolized somehow differently than 5FU is usually done. And this has less side effects, what the Asian colleagues tell me, but the enzyme which metabolizes the S1 to the effective 5FU form is not present in Western people. It's just something that Asian people do have, this enzyme combination that is needed for that. So if you give it to a patient in Egypt, he will not respond. If I give it to a patient in Hamburg, he will not respond. It's only effective in Asians.
Okay, I never heard about it. Okay, any questions? Please, if you have a question, raise your hand. Any questions? Last chance to ask a question to Dr. Thilo Hackert. So when you usually do this procedure, do you usually do you attack the metastasis and the primary at the same time, or do you do it staged?
It depends on the extent of resection. Usually we do the primary first anyway. And if you only have, let's say, 3 atypical liver resections, you can do this. If you have a more extended liver resection, like segment 2, 3 plus Whipple, we do it staged. Then we would do the Whipple first. And then, let's say, 8 to 10 days later, we would do the 2, 3 resection. And I told you that we do not really favor more extended liver resections, like hepatectomy right, hepatectomy left complete. We would be a little bit careful with that. Not at the same time.
Okay. Okay, any questions? Please, if you have a question, raise your hand. Dr. Medhat, do you have any questions? Ayo. He's back.
Yeah, because it فصل شحن بس.
Okay, it was
I have
disconnected.
2 questions. At first, when do you operate? When do you operate? Do you wait until you get the maximum effect on CA99? That's one question. Or you operate after so many courses of chemotherapy. Another
Yes.
question, did you do circulating tumor DNA in these patients to know if they are fit, they continue to have, to be free of disease? You know that the idea of oligometastasis is that you presume that if you remove these oligometastasis, there is no other metastasis elsewhere. The
Yes.
third question, will you give, for example, liver metastasis, a stereotactic radiotherapy with gating on the machine or not?
Okay,
Instead
so
of resection.
that's the first question. How long do we wait? We wait at least 6 cycles of chemotherapy. We prefer 8 to 9 cycles, probably. So not too early, not after 3 or 4 cycles. Depending a little bit on how the patient tolerates it, of course. If he does not
But
tolerate it,
do you wait until you get a maximum effect on CA99, or you don't bother with it?
yes, at least until we see a clear decrease in CA99. You never know when
Until
you
it
have
is
reached the maximum
stable,
effect.
maximum effect on CA99, right?
Yes, this is of course a good thing to guide. If you have the CA99 going down, this is fine. And then the second thing with the circulating tumor cells,
Yes.
we do this experimentally, but we do not include it in the routine.
Circulating tumor DNA, not circulating tumor cells.
Yes, or even the DNA. We do it, we measure it, but we do it only experimentally at the moment. It's not for the clinical routine decision. It's just something for studying at the moment.
Investigation again. How about the
Yes, investigation. And the stereotactic radiation,
therapy for metastasis?
we do not radiate the liver. No, this is not common in Germany. We do sometimes an RFA of selected liver metastasis, but this is also something which is rather an exception.
Investigation again.
Yes, investigation.
Okay. Thank you, Dr. Thilo.
You're welcome.
Okay, Dr. Haitham.
Hello. Hello.
Yes.
Sham, can you hear me? Yeah.
Yes, yes,
Thank
go
you,
ahead.
Professor Hackert. Okay. Thank you, Professor. And I want to ask if the patient primary has liver metastasis, then receive chemotherapy, and in next MRI after 3 months it disappear. When to operate? To wait more and more, and if it disappear, when to operate for weapon? What's the preferred time for you from your experience?
Yes, that's a little bit the question we discussed, that you wait, from my point of view, at least for 6 cycles of chemotherapy, and then you can go for the operation. So this is at least 3 months, but we prefer 6 months in the meantime. Yeah, that we increase the time of chemotherapy as long as the patient tolerates it.
Okay, and after a disappearance 6 months or total 6 months?
Excuse me?
The patient had metastasis and it disappeared after chemotherapy.
He means that complete resolution.
Complete resolution after, to immediately or after for a while, you can give more chemotherapy after it disappears.
No, when you have completed the chemotherapy and you think now you have the point of the best response, we would wait for 2 weeks and then operate. We would not wait until the tumor recurs somewhere from the imaging. So don't say this kind of time to test or time to wait or something that has been also advocated by some people. You have a complete response from the imaging. And then you say, no, do nothing anymore. Just wait until the tumor comes back. This is what we would not do.
Okay. Okay. I understand. Yeah. Thank you.
Welcome.
Thank you, Professor.
Okay. Any other questions? Please, if you have a question, raise your hand. Okay, looks like that was it. Hope you enjoyed it as much as we did.
I did. Thank you for the invitation again, and I hope to come to Cairo in person again.
Yes, I'll be looking forward to next time. I
Yeah,
really
great.
thought you were here, and I tried to text you, but you didn't reply.
Yeah, sorry. There was some kind of conflict of, as I said, appointments.
Yeah, that's okay. Okay, so always a pleasure having you with us, and looking forward to the next talk.
Okay, thank you very much. Have a nice
Thank
evening.
you, Dr. Hackert. Thank you all for joining us, and see you next week. Good night.
All right.
Bye bye.